Hey, Warlick. Are you there, Warlick?
Hey, John.
Hey, how you doing?
Fine, and you?
Good, good. Hold on. Let me get
Under pressure.
Hold on. Is this is Saeed, right?
Yes.
Okay, hold on. Look at my camera
Okay.
up there. Yeah, we gotta fix some questions, right?
Okay.
Okay, you're broadcasting to Miami Beach
Yes.
from Reunion Island. Okay,
Yes.
let me get up the Kahoot. You probably haven't used this before, right? Not many people have. Hold on. Okay. Let me screen share and you just lead me through the changes, okay?
Mm-hmm.
Okay. Okay.
Yeah.
Which particular question is? Okay, hold on. Let me edit. Okay. Okay, we'll just go over all of them, right? And let me.
The posterior part.
Okay, is that question right?
And there is it possible to change the question penetrates the
Yeah, of course.
posterolateral part?
Okay, which nerve? The lateral part?
Posterolateral.
Oh, posterolateral. Okay.
Postero. Yeah, I.
Postero. Okay.
Mm-hmm.
Lateral part of the okay.
Posterolateral part of the oculomotor triangle.
Okay. Huh?
Trigon. Oculomotor triangle. Okay. That's good.
That's okay. Okay.
Mm-hmm.
Okay. Any more? Let's see. Number 2.
Answer the human embryo of 10 week.
Okay.
Weeks. What is the question? What is the answer?
The answer: the brainstem is located. Can you see these answers?
Yeah. The tentorium contains much densely patched fibrous. No. The striate sinus is located. No, I don't see the. Okay. Wait a minute. Perhaps I change. No.
Okay, I got some things to do, so let's make this quick.
Is most posterior.
Yes. Before the webcast promotion is the most important. So I gotta go. You're gonna have to live with what you say. Okay.
It's a good question. It's good answer.
This answer okay?
Yes.
Okay. How about 3?
Yes, 3.
3's okay.
The shape of the tentorium, which I can't read.
Can you see the?
Yes, sir.
I'm in the way.
Okay. Back is in the relation of growth of the occipital lobe. And growth of the occipital lobe. 2 questions.
Is it okay or no?
Yes, okay.
Okay.
Which system is not at the level of the tentorial? Lamina terminalis, yes. Yes.
Okay.
And this give the exact response. Anterior part of V3 project into anterior incisor space in the median, in the medial project incisor space.
Is this okay?
In sagittal plane. Wait, we can change the question here. There's a good question, but it's
okay. What do you want to change?
We change the response here.
Give the what?
In the sagittal plane.
Oh, yeah. Okay. Which A, B, C, or D? Which one?
A.
A. Okay. In the medial.
Sagittal plane. Sagittal plane.
Okay, sagittal plane. Okay.
Yeah, medial sagittal plane. That's good.
Okay. Medial sag. That's it.
Yes, sagittal.
That's all I can fit. Because so that's the limit. Okay, we have to live with that. That's okay.
Yes.
I think people understand that. No, I can't do that. There's only so many spaces.
We can do sagittal plane.
Okay. Sagittal. Okay. Yeah, I know what you mean.
We can. Yes,
yeah, sometimes you can't use this.
Sagittal. Plane. Plane, yes.
Is that okay?
Okay, thanks.
Okay. Next one.
It's very difficult. The question
give the wrong answer. Is that right? Or do you want to change it?
Give the wrong answer in the middle incisor space. The ambient system is between medial surface of the ankles and the ambient system is between medial surface of the ankles and cerebral peduncle. No, it's wrong question.
It's okay?
No.
Okay, what do you want to do?
Wait, excuse me, I want to change this.
Okay.
This ambient, we change it by medial surface of the ankles and cerebral peduncle. By the...
Hey, Warlex.
Crural. See, crural.
Okay. Oh, see, where do you want to put cerebral peduncle?
No. The system, ambient system, like we replace crural system.
Okay, what do you want me to write there for a C?
C, yes, like we change ambient by crural.
Ambient by?
Yeah, crural. C-R-U-U. Yeah, say ambient. We
ambient?
We change ambient, yes. We change it.
Oh, change ambient, okay. To what?
Crural. C-R-U-R-A-L.
Okay.
Between medial surface of the ankles and the cerebral peduncle. Okay, the roof of the formed by give the middle incisor space. The optic.
You know, that's okay, Say. We're going to have to live with this. Okay? I mean, it's not a big deal. It's not a big deal. No, it's okay. Don't worry about it. It's not perfect. Nothing's going to be perfect. Hello,
Okay.
Warlix. How are you? Warlix, you going? Okay. Warlix, are you there?
Oh yeah, you hear me?
Hey, how you doing, Warlix?
Yeah, I'm good.
I thought you were at a restaurant. It said you were posting from a restaurant.
Oh yeah, just come back.
Oh, that's okay.
Yeah, because you text me.
Warlix, I don't know if you met Saeed. Saeed's from Reunion Island.
Yes, by mail. Yes.
Yes.
Yes, by
I think
mail.
we meet like many
Nice
times.
to meet you. And
Nice
happy
to
New
meet
Year.
you,
I
sir.
forgot. Happy New Year.
Hey, Happy New Year's too.
Thank you very much. Thank you very much.
Okay, I'll be back, Warlix. Okay.
It's very nice to have you today.
Thank you very much. It's a great pleasure for us.
I see your request for the cartoon is really nice. So we going to work out on the advertise more on the Facebook.
Yeah, we have lots of time on Warlix. We have like 20 minutes. So.
20 minutes. Okay.
John.
Yeah.
Yeah, it's a complicated subject, the incisura, tentorial incisura, and it necessitates more time.
Yeah. Okay. All right.
I have how many time?
Well, as long as you want, really, most an hour 15, hour half,
Yes.
whatever. It can be less. If you want it less, that's fine too.
Yes. Okay.
I don't want to make Warlix angry.
Yeah.
If she gets mad, whatever makes her happy.
Because it's.
Warlix, are you alive today or what? Warlix, can you hear me? I don't think you can hear me, Warlix. Okay. Whatever. Okay. Yeah. Like 45 minutes, whatever you want. Probably 45 minutes would be good. How long did you plan on it? Was there any plan you had?
1 hour, 1 hour 15.
Okay, that's fine. That's fine. That's fine with me. We have the quiz
because it's very interesting subject, and I can't do that on 30 or 45 minutes. That's not enough.
Just take your time. Take your time. Take your time.
Okay.
We have lots of time. We have lots of time. That's one thing I want to make different about this platform is that we don't have so much time restriction, because sometimes things get going well and you hate to stop a presentation. Just like, when you're at a conference, you know how sometimes the discussion gets going good and they have to stop because they don't have time.
Yes, okay.
But we have time. We have time. So we can go as
long
as you want.
The problem for me, it's English. I'm not fluent, but...
No, your English is perfect. It's better than most. Don't worry about it. No, it's very good. Just take your time, and this is not going to be perfect. We make mistakes, but we just keep trying, and everyone knows we're sincere and we're trying our best. There'll be some tech issues, but that's okay. Don't worry about it.
Okay, thank you very much.
So let me see, and then actually this time I like to use to introduce people to you, to meet you. Does anybody want to meet Saeed? Because I think this is a very good benefit of this type of platform. You get to meet people from different parts of the world. Most people are shy, but I understand that. You don't have to put your face on the camera. But if you want to meet me or Saeed just before we start, you're welcome to come in right now and say hello. But if you don't want to, that's fine too. You can just watch the presentation, try to get as much out of it and we take the quiz after.
Yes. Can I share my slides?
Yeah. You want to practice something, or you want to?
Yeah.
Okay. Yeah. Go ahead. You'll be all right. I can hear you. I'll just be off the screen here.
Okay.
Go ahead. Go ahead. Yeah, that's fine.
Yeah. Yeah. That's interesting point. That from Réunion Island is a French department. It's Europe.
Oh, okay.
Yes.
That's interesting. Now, do you have any videos?
We can have a video. Yes.
No, it's. I just need to know so we can practice them if you're going to use them. You know, 'cause sometimes there's problems with video.
Videos for Réunion Islands.
No, whatever video you're going to play, I'd like to.
Yes. I have
like to play it now to practice.
Yes. I have videos. Yes.
Okay, so why don't you play it? I want to see you. I want to see you practice it.
Okay.
To make sure we get it okay.
Yeah.
With the sound and is there sound on the video? Hello.
No sound. It's the video of Taha for the.
Oh, no sound. Okay, don't worry about it then, because there'll be no problem.
Yes.
Because with the sound, you have to adjust the platform. So
yes,
I think there's someone that wants to meet you. Hello, from India. Is there a resident here that wants to meet us? Let me see here. Dr. Sharma. Hi, from India.
Yes,
do you want to come in there? Hey, there we go.
Where
are you?
Of course.
Yeah, can you get off the screen share, please? I'm going to get Dr. Saeed off the screen share so we can meet you properly. Okay. Yeah, I'm Dr. Bennett. This is Saeed.
Hey, hi.
Giving the lecture, and this is. Go ahead. Introduce yourself, please.
So I am Dr. Tarunesh. I'm a resident at AIIMS Jodhpur in India. I have been on webinars. I've been seeing webinars, a lot of webinars.
Great.
Hi, John. They are all great.
You don't have to say that. You can. You're welcome, anyways. But this is the time to kind of meet people. Like we're going to try to make it so that you can kind of network before, and then Saeed will give his formal presentation, and then network after if you want, because this is a benefit.
Yes.
You'll be looking for a fellowship someday in another part of the world or whatever, and it's good to start meeting people now. Okay, so let me see. Is there anyone else that would like to introduce themselves? We have a few minutes here before we start. Oh, you don't have to, but if you're welcome to, certainly come in and say hello. If not, I'm going to step away and do a little. Hello, Dr. Xing. You want to say hello?
Hello, everyone.
Hey, welcome. Where are you from?
I'm from Malaysia, from Penang, Malaysia. I'm currently in the operation theater, waiting to do a decompressive cranectomy in a short while.
Oh,
so we've got the time to catch up for a while.
Welcome. This is Saeed. It's just so you meet him informally from Réunion Island, and Taha Sharma is from India.
Yes.
We want you guys to meet other people from other parts of the world.
Yes. Do you know Réunion Island? Where is your Réunion Island? A small island. It's a beautiful island, small.
You know, I didn't know where it was.
I would like to visit one day, sir.
Wait, can I? Can I have my slides?
Yeah, sure. Go ahead. We start in about 15 minutes.
Do you see my slide? my slides?
Not yet. Not yet.
Not yet.
No, you're not sharing.
Excuse me. Okay. Ok, partager l'écran. And now?
Yes, we can see it now.
Yeah, you can see it?
Yeah. Yeah, Warlick, did you know that part of the brain is very complicated? Did you know, is it complicated to you, Warlick?
Yeah, it's they have a lot of veins involved.
That's what makes it complicated, the venous.
Yes, actually, every place of brain is complicated. We should not underestimate.
That's
it.
why we have neurosurgeons.
Here is my island.
Oh,
it looks beautiful.
Where's that?
Yeah, take on a tour.
Here is Reunion Island. You see my slide?
Hey,
yes.
Saeed, could you do this at the beginning of the broadcast? Kind of take us around at the beginning? Can you do that? Or would you rather not?
What? This presentation?
Yeah, a tour of the island.
My island?
Yeah, can you do that when you start?
Okay.
You don't have to if you don't want to.
I decided to do it in the end of the presentation.
Okay, fine. Do that. That's fine. That's fine.
Okay.
But Warlocks is the boss. Is that okay, Warlocks?
Yeah, I want to know like why I do the poster presentations.
Yeah, let's do it.
I don't know where it is too, but as I see it from his map, it's look really beautiful and interesting.
Yes, it's very nice, beautiful. Look, that we are many religion, many multicultural island, and we live in peace. There's beautiful island. There's a mountain. There's ocean. There's volcano.
I wonder that in that island, do you have a COVID situations there?
There is less. We have some cases of,
but not much, right?
Not much. Not.
Oh, that's so nice.
This is my hospital and my colleague.
Oh, looks so nice.
Yes.
The scenery is so peaceful. It looks like.
This is my colleague, 3D anatomy from Alicante. Like so, we talk about.
Oh, you have volcano too. Is that peace now, or it's still like awaiting to erupt?
The volcano?
Yeah.
No, it's in rest. He's sleeping now, but he's very active, very active.
Oh.
That's the very nice spectacle. It's very beautiful.
So most parts. So your hospital is near the beach, near like.
Yes.
Oh, so
few meters from the ocean.
Wow.
Yeah, you know, we have a neurosurgeon from India that used to participate in these webcasts named Rakesh. He went to a honeymoon in the Seychelles Island. A lot of honeymooners go there, huh?
Yeah. It's beautiful. Yeah, the very beautiful islands there. Yeah.
So the Reunion is part of the Seychelles. Is it considered part of?
No. If you look here, there's Madagascar here.
Okay.
Madagascar. Here, there is 2 points: Reunion Island and Mauritius. And Seychelles are here.
Oh, it's completely different. Wow.
Yes, different.
Oh,
yes.
Okay.
Just different.
Yeah, I thought it
this
was
region.
I thought it was the same.
And I work here in Saint-Pierre, in this region, this town, Saint-Pierre.
Wow. Is the ocean, does it have sand or is it kind of rocky?
I don't understand what.
Is it sandy beaches there, or is it mostly rocky?
There are sandy and rocky.
There's both types, huh?
We are sandy here in this part of the island.
On the south, the western
on the
part?
east, in the west of the island.
Oh, okay.
Here the volcano, La Fournaise. The name is La Fournaise.
What is your national language? English?
French.
Or French?
French, yes. French, but the most more than half talk Creole.
Wow, Creole. It must be one of the only places in the world besides Haiti that speaks Creole.
Yes, they speak Creole, yes.
Have Chinese temples and
yes, there are many different
it's
religions.
like multi religions,
yeah.
Interesting. It's on one island too. Wow.
yeah, small islands, but it's very beautiful. It's like a point in the ocean when we look. That's it's very beautiful island. There are many parts to see on the island. And you're welcome.
Yes, of course, after COVID, for sure. COVID like destroy everything.
Yeah.
Maybe about 8 minutes. Okay.
We start in 7 minutes.
Yeah.
Yes. Okay. Just I take water.
Yeah. Okay. get you off there. Yeah, we are going to do a Zoom, excuse me, a Kahoot quiz after Saeed's presentation. And I don't know, you guys probably don't understand it, but you go to Kahoot.it, and we have a few minutes, Saeed, so I can show people this.
Yes.
I'm just gonna basically show them, and you know how to do it, right, Warlicks? Okay, I'm gonna screen share what people are going to see. Okay, everyone listening out there in internet land as well as panel, go to Kahoot.it. Okay, and you'll get a screen like that. And I'm going to give you the pin at the end of the webinar, and you're going to put that pin in and enter into the Kahoot quiz. I don't know, Warlicks, what should we give for prizes? A trip to Reunion Island.
Yes. Yes.
The check is in the mail.
First class.
First class. But anyways, that's how you're going to vote. So keep your, and this is done from a smartphone. I'm sorry, I didn't mention that. Go to Kahoot.it on your smartphone. That's how you're going to vote. Because once you get in it, put the pin in, you're able to vote on your smartphone. So have your smartphone handy, open to Kahoot.it, which is the screen, and I'll give you the key later. Do you feel the excitement, Warlicks, about having the quiz and everything, or no?
Yeah.
Do you feel the excitement or no?
Yeah, so excited.
Okay, that's better. Go crazy. Oh, we have a lot of people. Wow, in the waiting room. Wow, great. They're coming in. Okay, 1 minute. We start.
Victor is here. Victor Hugo Perez.
Vic, not yet. Yeah, I'm gonna text him to make. He loves these. He can talk neuroanatomy 24 hours a day. He's like that. You know? Do you know people like that, Warlicks? Some people just love neuroanatomy, man. They can talk it.
I still doing my normal life.
Really? Yeah. Like you prefer the normal life? Okay.
Yeah.
Okay. We're almost ready. Okay. We're ready to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from beautiful sunny Miami Beach. This is Dr. John Bennett for neurosurgery. Actually, it should be Neuroanatomy TV. I screwed up, Warlicks, again. Should be Neuroanatomy TV, or could be Neurosurgical TV. Anyways, we're graced with the presence of Saeed Taha. He's a neurosurgeon from Reunion Island, off the coast of Africa, off Madagascar. And we have some distinguished panelists, but I'll let Warlicks handle it from here because she has more perspective of the topic. Hello, Warlicks.
Hi, John. Thank you very much. So welcome everybody to Neuroanatomy TV. Today we have a very interesting neuroanatomy topics about the tentorial incisura, in which it's one of the complicated anatomy and very necessary for the neurosurgeons to know that the anatomy in this region very well before you go and do the surgery. So let's hear Dr. Saeed Taha, please.
Okay. Thank you very much, and Happy New Year for all and I will start my presentation. Excuse me. Can I start my presentation?
Not yet.
Alex.
Take your time. Take your time.
Okay. How can I change my? Ah, yes. Excuse me.
There you go. Okay.
Okay.
Okay. You want to make it bigger? That's.
Yeah. Okay.
Okay. Yeah. At the. Yeah. Okay.
No. Yeah.
Not yet. That's you're taking us on a tour, which I like, but I don't think you want to do that.
Well,
Oh, take your time.
okay.
Take your time. We can always edit this out. This will be edited out. No problem. There you go. That's okay. Now to make that slide big, you know how to go to the bottom of the screen, right? To make this.
Yes.
There you go. Perfect. Perfect.
Okay. Just so we try to present today the tentorial incisura. It's a very complicated area. It's this region. It's reminded for many years as an impregnable citadel, and always remain a real challenge for neurosurgeon because complexity of neurovascular relationships, vital structures in this region, and narrow access to this area. So we start with the base. The tentorium supports cerebellum and cover cerebellum and forms a collar around the brainstem. That's slapped down from its apex to posterior edge of the incisura to attachment in the inner surface of the occipital and temporal bone, and anteriorly to the petrous ridge, and the attachment of the and the free edge. The free edge is classically U-shaped or rotely triangular, but from my point of view, it's ogival shape or ogival like ogive arc because it's a three-dimensional shape. The anterior end of each free edge is attached to petrous apex and the anterior and posterior clinoid process. The three folds, there are three folds that appears from that with the anterior and posterior petroclinoid fold and anterior.
Excuse me, Saeed.
Yes.
Yeah,
yes.
I'd like to say that Victor Hugo Perez just came in.
Yes.
Hey, Victor, are you there?
Hi,
say hello to Saeed. Well, I guess maybe he stepped away. Okay, anyways, he's here, Saeed.
Okay, thank you.
Okay.
And the dura folds, we have anterior and posterior petroclival fold and intercranial fold. For the shape of this free edge, it's more ogival, as we say, as we see. Here, this is the tentorium with the free edge. That's part behind the brainstem, and cover the upper part of the cerebellum. That's the three-dimensional shape, as in not triangular or U shape. We continue. This folds demarcate what we know, a triangle, oculomotor triangle. This is the anterior fold. This is the posterior fold. And here we are the anteroclinoidal fold. The anterior petroclinoidal fold comes from petrous apex to anterior clinoid process. Posterior clinoidal fold from petrous apex to posterior clinoid, and anteroclinoidal fold extends from anterior to posterior clinoidal process. There is a petrous spinal ligament that passes below the posterior petroclinoidal fold from the petrous apex to lateral border of dorsum selae. And between these folds, we are oculomotor triangle that's here, oculomotor triangle, that the oculomotor triangle pierces in the center, and the trochlear nerve pierces this triangle in the posterolateral part of this triangle, and abducens nerve enters cavernous sinus by passing below the petrosphenoidal ligament. Again, this beautiful image of this region with the anterior fold more marked, and anteroclinoidal fold and posterior fold. Excuse me. For the dura mater. The dura mater is the start with formation of perimeter mesenchyme, including primitive and streak and neural crest. It starts at delicate bilateral separated folds, and the embryology here. We have the embryo of this is the work from Kleinworth in 1968 with the Tentorial two folds, separate folds. They are lucent and the midbrain very far and posterior, very posterior. And here 20 weeks old human fetus with the dura is more less lucent, and finally into 32 weeks it's a dura of adults. Here the histological slide of the 8 weeks of human embryo with loosely arranged stroma with the flattened mesothelial cells with rare vascular structure. 20 weeks human fetus, there are numerous bundles of collagen and blood vessel, and in the human tentorium, it's densely fibrous dura. This is a work from Kier, and this is an embryo of 11 weeks. When we see in sagittal plane, and we see here the development of the tectum, the big tectum and the small cerebrum. And here in excuse me, I can't see my slide. Yeah, 15 weeks. We have a development of the occipital lobe with reduction, involution of tectum, and finally to here to 30 weeks, and we have a morphological definitive morphology. So how we explain this obliquity of tentorium? That's what we call a retroflexion of tentorium. This is due to the cerebrum is being the greater part of the infratentorial volume in the human, and commences growth later, but completes growth earlier than most parts of the brain. So there is a dynamic phenomena with the growth initially of the brain, and reduction of the growth of the brain, and the start the growth of the cerebellum, and after the definitive growth of the cerebrum. I will this slide just for explaining the duration of the incisor space is located here. Here, this is the tentorial notch. There is a print, the reconstruction of the system from New News. And this is injection modeling of the basal system by Professor Salomon from Marseille in French. And we can see here the optic chiasm, the optic nerve, the suprachiasmatic system. Here the print of the brainstem, the peduncle, with here the ambient system. The basal system is the roadmaps for neurosurgeon. That's we know that arachnoid. We have an outer arachnoid membrane, or basal and convex, that separate the subarachnoidal space from subdural space, and inner arachnoid membrane that's adherent to the PIAB, and between this structure there are arachnoidal trabecula, or membrane, the hard membrane, and this membrane is are concentrated in the region where we have many vascular structure. So there's still non-unified nomenclature and classification of the arachnoid membranes. As we see here, this is the classification from my friend Frelich from Lariboisière, Paris, and this is classification of Zhang. But for the resident, the best paper is the paper of Peter Kahoot, who described this arachnoidal membrane because he do this in cadaver, fresh cadaver, and with the endoscopic technique that with the keyhole approaches. This is a very interesting paper. The system are divided in supratentorial, infratentorial, and paired and impaired, and the system at the level of the tentorium. This is our incisor space, our tentorial incisor spaces, and we have in this region the lamina terminalis, chiasmatic system, interpeduncular system, the upper parts of the pontine system, and back the quadrigeminal system. Laterally, we have ambient system, crural system, carotid system. In the middle, we have interpeduncular system, pericallosal system, and olfactive system laterally. This is image from above with the different spaces, anterior spaces, middle spaces, and posterior spaces, incisor spaces. Again, here the anterior incisor space located anterior to the peduncle, cerebral peduncle, and extends to the infracallosal, pericallosal region. The incisor space are divided in three parts: anterior incisor space, paired middle incisor space, and posterior incisor space. I don't treat in this presentation the herniation, tentorial herniation, but the width of the anterior diameter between the anterior clivus, it's very important, because when we have this width inferior to 20 millimeter, with this, and we decide to go to, for example, for a basilar artery or superior cerebral artery, we should plan that other than a simple pterional approach. We should do perhaps subtemporal approach with or without resection of the clinoid process. The anterior incisor space is located anterior to midbrain and the pons, and extends inferiorly between the brainstem and the ancus, and extend obliquely and forward around the optic chiasm in the subcallosal area, opens laterally here in the medial part of the sylvian fissure, and opens posteriorly between ancus and the midbrain to the middle incisor space, and below the optic chiasm, the anterior incisor space has posterolateral wall formed by the ancus and the posterior wall by the peduncle and the pons. Above the optic chiasma, we have the rostrum of corpus callosum. Posteriorly, the lamina terminalis here, and laterally, the medial surface of the frontal lobe below the rostrum, with paraterminal, para-olfactory, gyrus rectus, anterior and posterior para-olfactory sulci. It's open laterally in the sylvian fissure, situated below the anterior perforated space, and the anterior limb of anterior capsule, the head of capsule of caudate capsule, and anterior parts of the lentiform nucleus are situated above the anterior perforated space. Here again, we have the lamina terminalis, and laterally we have paraterminal gyrus para-olfactory gyrus, and the medial part of gyrus rectus. From the above, we have the genu of the internal capsula and the caudate nucleus, head of caudate nucleus, and the foramen of Moro above the anterior incisor space. Here again, this is a anterior perforated substance, and we have lenticular nucleus here, the caudate nucleus here, and the frontal horn. Here we have the projection of the foramen of Moro. About system, we have antipeduncular system between peduncle cister and dorsum selae that communicates. It communicates laterally with the sylvian system below the anterior-posterior system, and anteriorly with chiasmatic system below the optic chiasm. And the antipeduncular and chiasmatic system are separated by the Liliequist membrane, the membrane of Liliequist that extends from the dorsum of the dorsum selae to the region of the mammillary body. The chiasmatic system communicates with the systema lamina terminalis. For the ventricular relationship, as we see, the anterior part of the third ventricle is projects into the anterior incisor space. In the medial plane, we have supra and infrachiasmatic portions. I think, yes. Yes, we have a third ventricle here with the portion, infrachiasmatic portion, and suprachiasmatic portion. The frontal horn of the lateral ventricle is located above the anterior incisor space. As we see, the anscus surface forming the posterior wall of the anterior incisor space, and temporal horn is separated from anscus by the amygdaloid nucleus. The cranial nerves, olfactory tract runs posteriorly and splits in medial and lateral striae that form the margin of the anterior perforating substance. And the optic nerve comes from the canal medial to the attachment of the 3H to the anterior clinoid process, direct posteriorly, superiorly, and medially toward the chiasma. Optic chiasm usually above the diaphragm selae, but maybe post-fixed near the tubercle selae, or post-fixed at the level of the dorsum selae. The optic tract continues posterolaterally around the cerebellar peduncle to enter middle incisoral space, as we see here. Oculomotor nerve comes from the medial surface of the peduncle, passes below the cerebral, between posterior cerebral artery and the superior cerebral artery, inferior to the ankles to enter the roof of the cavernous sinus and the oculomotor triangle. The abducens nerve ascends from deep within the infra-tentorial area of the anterior incisor space. From the pontomedullary surface ascends in the prepontine system to pierce the dura covering the clivus and passes below the petrosphenoidal ligament to enter the cavernous sinus. Here again, the trigon, the oculomotor trigon, and the oculomotor has a system portion before entering the cavernous sinus. Arterial relationships is the most complicated region because we have all the components of the circle of Willis. The anterior carotid artery enters this space by passing along the medial surface of the anterior clinoid process and bifurcates below the anterior perforated substance. The posterior communicating artery arises from posterior medial aspects of the anterior internal carotid artery, courses superomedially to the third nerve to join the posterior cerebral artery. For the anterior choroidal artery, it comes from the posterior parts of the anterior carotid artery, 0.1 to 3 millimeter distal to the origin of the PCOM, and directed below the optic tract, enter middle incisor space in the crural system. The anterior cerebral artery, we have the proximal part of this artery below the anterior perforated substance and course anteromedially above the optic chiasm and the anterior communicating artery. For the middle cerebral artery, it comes from below the anterior perforated artery, and major bifurcation are located in the lateral part of the anterior incisor space. The basilar artery gives rise to posterior cerebral artery and superior cerebral artery in the posterior part of the anterior incisor space between posterior perforating space and the clivus. And the basilar tip can from as far caudal 1.3 millimeter below the pontomesencephalic sulcus to as far rostral as the mammillary body. For the posterior cerebral artery, it goes around the peduncle cerebral peduncle above the third nerve and exits by coursing below the ancus and the cerebral peduncle to enter the middle incisor space. The superior cerebral artery is located below the PCA and course laterally below the third nerve, and the origin usually rostral to the level of the free edge. It dips below the tentorium to reach superior surface of the cerebellum at the junction between anterior and the middle incisor space. Here, here again, this region, this is a circle of Willis with the important perforating from anterior cerebral artery, communicating artery, posterior posterior communicating artery, Sylvian artery, superior and posterior cerebral artery and superior cerebellar arteries. So it's a rich vascular region. And in this slide, this is from a Korean journal, demonstrated the perforated arteries communicating from the posterior communicating artery, and the perforating arteries here from mostly the proximal part of the posterior cerebral artery and posterior communicating artery. Here again, the perforating artery are here between the peduncle, cerebral peduncle, and in this slide we can see here the perforated artery. That this is thalamo-perforated artery. This is the third nerve. This is mammillary bodies. This is the third ventricle, the chiasma. This is the optic tract, the optic recess, lamina terminalis, the anterior commissure. This is fornix. Here we say the hypothalamic sulcus. Here middle tegment, mesencephalic tegmental portion. Here the gray periapical matter, and here the tactile plate, tactile plate. Here we have the pineal gland, and here the velum interpositum. For the venous relationships, basal vein is the important vein of drainage, and courses from the anterior to posterior incisor space to the vein of Galen. It originates from the anterior incisor space below the anterior perforated substance here, and drain deep Sylvian vein, inferior striate vein, olfactory veins, and anterior cerebellar vein. Here again, the anterior cerebellar basal vein. And here we have the middle incisor space with the crura system here and the ambient system in this region. Again, crura system, crura system and the ambient system. Here is a beautiful hemisphere with here the area middle incisor space is located here. This is the thalamus and the pulvinar of the right side. Here we can see the corpus callosum, the splenium of the corpus callosum. Here the cingulate gyrus, and above the precuneus lobe, and the precuneus are separated from the cuneus by parieto-occipital sulcus, and separated, the cuneus is separated from the lingual, beautiful lingual here, by the calcarine sulcus. The calcarine sulcus and the parieto-occipital sulcus fuse here to create the anti-calcarine sulcus that separates the isthmus of the cingulate gyrus from the parahippocampal gyrus. The middle accessory space is located lateral to the brainstem, extend upward between the temporal lobe and the midbrain, extend downward between the cerebral and upper brainstem. It has medial lateral walls and roof. The medial wall is the lateral surface of midbrain, and the upper pons divided by the pontomesencephalic sulcus at the level of the free edge. We have a large part formed by the cerebral peduncle, and smaller part, posterior part, formed by the tegmental surface. The optic tract at the upper edge of the, we have the optic tract of the upper edge of the cerebral peduncle, and the tegmental and peduncular surface are separated by the lateral mesencephalic sulcus. Here, inferior view of the brain, with the removal of the temporal lobe. Here we have optic radiation, and here the atrium of the ventricle, lateral ventricle, and here we have the large portion formed by the peduncle, cerebral peduncle, and a small portion formed by the surface, tegmental surface, that's separated by the lateral mesencephalic sulcus. The roof is formed by the optic tract that lies between the peduncle and the ancus. We return to the roof. The roof of the middle accessory space has a narrow anterior part, the posterior part of the optic tract flattened between ancus and cerebral peduncle, and wider posterior part if we look from above, the inferior surface of the thalamus, and the lateral geniculate body that protrudes from the lower surface of the thalamus behind the ancus, and the medial geniculate body posterior medial to the lateral geniculated body behind the lateral mesencephalic sulcus. Here the anterior part, narrow anterior part, and the large posterior part, with the inferior part of the thalamus with a pulvinar and medial geniculate body, and the lateral geniculate body in the lateral portion. the lateral wall of the supratentorial part is formed by the hippocampal formation on the medial surface of temporal lobe. This region corresponds to the parahippocampal gyrus, dentate gyrus, and fimbria of the fornix. Here, the anterior superior view with the removal of the brainstem, thalamus, superior peduncle, and we have here the temporal horn with the hippocampus here. The fimbria is located at the upper part of the medial wall. Dentate gyrus is located here, and the subiculum is located in this area. The middle incisoral space, we will see it in a few minutes. This is the ambient system, and this is the crural system. And the ambient system are supratentorial part and the infratentorial part. Here again, the parahippocampus gyrus with the atrium, and this parahippocampal gyrus separates the atrium from the middle incisoral space. This is a subtemporal exposition of the anterior and medial incisoral space. It's the approach of subtemporal approach when we need to operate by subtemporal approach, the lesion in the middle incisoral space. We see here the carotid, here here the posterior cerebral artery, that's posterior cerebral artery, the third nerve, superior cerebral artery, that's has a short part segment, supratentorial, and go and goes in the infratentorial space. The cisternal relationships, as we see, the crural cistern is located between cerebral peduncle and the ancus, is posterolateral to is a posterolateral extension of the anteropeduncular system, opens posteriorly in the ambient system. Ambient system medial portion of the medial is located in the medial portion of the midbrain, and above the pulvinar, and laterally we have a limbic system. It continues posteriorly with quadrigeminal system. Some authors consider this middle incisor space as ambient system, because there are no membrane that separe, no separation between crural and ambient system. The ventricular relationships, the temporal horn extend in the medial part of temporal lobe, lateral to the middle incisor space, and 3 centimeters from the temporal pole. The choroidal fissure between fimbriae and lower surface of the thalamus is the seat of the attachment of the choroidal plexus and temporal horn. The cranial nerve has the longest course in the brain and within this incisura space. It's arise below the inferior colliculus in the posterior incisura space, but can be raised just lateral to the inferior colliculus. Pass forward through the middle incisura space between the PC and posterior cerebral artery and the superior cerebral artery. Its initial course around the midbrain is medial to the free edge in the space between the tectum and the cerebellum, and reach the free edge at the posterior edge of the cerebral peduncle. And this is a most important point for the neurosurgeon when we operate the patient by a subtemporal approach. When the space is destroyed by the tumor, we can reach the trochlear nerve in the space behind the peduncle, posterior part of the cerebral peduncle before opening of the dura. Before opening the dura. It pierces the free edge posterior in the posterior part of the oculomotor triangle, runs a short distance and arterial petroclinoid fold, and enters the wall, lateral wall of the cavernous sinus. The trigeminal nerve arises on the anterolateral aspects of midpunch, passes above the petrous apex until the Meckel's cave. It divides into the three sensory roots and is located below the free edge. Here the slides with the trochlear nerve. Here it appears inferior portion of the inferior colliculus and run lateral to midbrain between the inferior cerebral superior cerebral artery and posterior cerebral artery. Runs few millimeter along the free edge before piercing it in the posterior part of the oculomotor triangle. The arterial relationships, the anterior choroidal artery arise from superior part of the middle incisor space below the optic tract, passes through inferior choroidal fissure near inferior choroidal point to supply the choroidal plexus of temporal horn. This artery, as we see, rise from the internal carotid artery. The posterior cerebral artery between the runs between the cerebral peduncle and the incus and passes straight posteriorly but between tegmentum and subiculum, gives off several cortical branch to inferior surface temporal of temporal and occipital lobes, and lateral to the posterior choroidal artery. Lateral posterior choroidal artery origin in the middle incisor space and course superolaterally through the choroidal fissure and around the purvinar to reach choroidal plexus in temporal horn and atrium. The middle posterior choroidal artery originates from the proximal part of the posterior cerebral artery in the anterior incisor space, courses parallel and medial to PC in the medial, the posterior cerebral artery in the middle incisor space to reach posterior incisor space. The thalamo-geniculate arteries arise below the purvinar, as was distal part of the posterior cerebral artery in the middle space, pass upward through the geniculate bodies to reach the thalamus and the internal capsule. Peduncular perforating arteries from P2 and sometimes from P1 from superior surface of the posterior cerebral artery. They course to the cerebral peduncle to irrigate the corticospinal and corticobulbar tract, substantia nigra, red nucleus, mesencephalic tegmentum, and nucleus of the third nerve. And the circumflex arteries, we have two circumflex arteries, short and long circumflex arteries. The short circumflex arteries arise from P1 or P2 in 15% of case. They are formed by 1 to 3 arterial branch. They are medial to P2R, the proximal portion of the post-communicating artery and posterior medial choroidal artery and the lateral choroidal artery, given off cerebral pedunculate and medial geniculated branch. The lateral circumflex arteries arise more from P1 than P to proximal parts before the communicating artery. 1, 2, or 2 branches traverse crural ambient and quadrigeminal system to irrigate quadrigeminal plate. They give off branch to cerebral peduncle, medial geniculate body, and purvinar. This is the important arteries, the perforating arteries, and surgically it's the most important point when we operated the medial incisor space, especially when we come from the subtemporal approach. This again another slide with the long circular artery circumflex arteries here, the number 4, and we have the medial and posterior lateral posterior medial choroidal artery, the 5 and the 10, and this is the anterior temporal artery. The superior cerebral artery passes below the level of the free edge, bifurcates into rostral on the caudal trunk at the lateral margin of the cerebral peduncle to enter middle incisor space. It passes above the 5th nerve and enters the cerebral mesencephalic fissure in the anterior part of the middle incisor space. The walls in supra tentorial parts of the middle incisor space are essentially irrigated by perforated branch from the anterior corridor artery and PCA, and the wall of the anterior infratentorial parts of the middle incisor space are supplied by the anterior superior cerebellar superior cerebral artery. There's a problem here. The venous relationships, the basal vein course along the upper part of the cerebral peduncle and below the pulvinar to reach the posterior incisor space. It may infrequently terminate in tentorial sinus in the free age at the level at this level, and here this is an important point when we go by the inferior tentorial approach or superior supracerebellar infratentorial, and we need to open the dura. We need to see the angiogram on the MRI with angio to study the basal, the vein, the drainage vein of the temporal lobe. The tributaries vein are peduncular vein, lateral mesocephalic vein, and inferior ventricular vein. The tributaries of inferior ventricular vein are anterior hypocampal, anterior longitudinal hypocampal, and medial temporal cortical arteries. Vein. Here again, the basal vein around the middle incisor space, with the temporal drainage here, and to continue to the ambient system, and we start the posterior incisor space. Excuse me. The posterior incisor space, a posterior to midbrain, represented by the pineal region. It has a roof, a floor, and anterior and lateral walls, and extend backward to the level of tentorial apex. The quadrigeminal plate is the center of the anterior wall, and the pineal body is rostral to the colliculi. Habenaral commissure forms the upper part half, and the posterior commissure forms the lower half of the attachment of the pineal body to posterior parts of the third ventricle. We're here. This is the quadrigeminal plate with the colliculi. The pineal body is above the colliculi, and it's attached to the posterior part of the third ventricle by the habenaral commissure in the upper part, and the posterior commissure in the inferior part. The parts of the anterior wall below the colliculi in the medial midline is represented by the lingula of the vermis and lateral superior cerebral peduncle. Excuse me. The roof is presented by the lower surface of the splenium, and contain the terminal part of the crura of the fornices and hippocampal commissure. Here is the superior peduncle cerebrum and the and in the medial part.
Excuse me, Saeed, do you want to take a minute and have a drink, have a glass of water
Yes,
or something?
Okay, thank you.
Yeah, there's no hurry. This is relaxed. Take your time. Take your time. And yeah, it seems complicated to me.
Yes. The roof of the posterior incisor space, the lower represent the lower surface of the splenium, and the terminal part of the crura of the fornices and hippocampal commissure. The floor is represented by the culmen of the vermis in the midline and the quadrangular lobule laterally. Inferiorly, the posterior incisor space extends into the cerebral mesencephalic fissure. Each lateral wall formed by pulvinar cruise of the fornix medial surface of the medial surface of the cerebral hemisphere. The anterior part of this lateral part is represented by the pulvinar, which is located laterally to the pineal body, and posterior parts by the pulvinar and the crus of the fornix that wraps around the margin of the pulvinar, and more posteriorly the parahippocampal gyrus with the dentite and the gyrus, with dentite gyrus. Parahippocampal gyrus and the dentite gyrus, excuse me. Here is it's a complicated space, even without vascular structure, but unfortunately here we haven't perhaps here the crus that pass around the pulvinar. And this is the peduncle, cerebral peduncle, more anterior, the quadrangular cerebellum is here in this region. Here again, the posterior part of this region with the habenular habenular commissure. This habenular commissure is the stria medullaris of the thalamus that run over the anterior surface of the thalamus. And here the pineal body, laterally superior colliculus, and laterally the posterior part of the thalamus. The cisternal relationships is formed by the quadrigeminal cister, posterior to the quadrigeminal plate, communicates above with posterior pericallosal cistern, inferiorly into a cerebral mesencephalic fissure, inferiorly in posterior parts of the ambient system located between the midbrain and the parahippocampal gyres, laterally into the retrothalamic area, the medial to the crus and of the fornix, and may communicate with the velum anteropositum between the septum above the penile body. Between the splenium and the penile body. This video to show just see the velum anteropositum and the MRI. It's the upper part of the roof of the third ventricle. The posterior incisor, the venous relationships. There is the most complex venous relationships in this part of the cranium. The anterior cerebral and vein and basal veins, and many of their tributaries converge on the vein of Galen. The anterior cerebral vein exit the velum anteropositum and basal vein exists the ambient system to reach the posterior incisor space, where they join the vein of Galen. They passes below the splenium to enter the striate, the sinus at the apex of the tentorium. Here, this is infratentorial view of this area. It's complex. There is without arachnoid, without blood, without it's very complicated area. And here we have cerebral mesencephalic vein, internal cerebral vein, and internal occipital vein that converge to the Galen vein. And if we made choice the supratentorial, middle infra tentorial and supracerebral approach, this region is very complicated. We have directly this vein, and we can have some problem with this vein. For this reason, the paramedian supracerebral infratentorial approach is best than median. The outer relationships are formed by trunks and branch of the posterior cerebral artery and superior cerebral artery as they enter the posterior incisor space from anteriorly. The posterior cerebral artery courses along the lateral part of the posterior incisor space, bifurcates into calcarine and parieto-occipital arteries, where it crosses about the free edge. The medial posterior choroidal arteries enter the posterior incisor space from anteriorly, turn forward beside the pinea, and enter the velum anteropositum to supply the choroid plexus and the roof of the third ventricle and the body of the lateral ventricle. The lateral posterior choroidal artery arises in the posterior incisor space around the posterior medial surface of the pulvinar, supply the choroidal plexus of the atrium, and give branch to the thalamus. The superior cerebral artery, upon exciting the cerebellomedullary fissure, gives branches to free edge to supply the tentorium surface. And the perforating branch from the PCA and the SCA and the MCA supply the walls of the posterior incisoral space. Here again, under the posterior cerebral artery and superior cerebral artery that run along the crural and the ambient system to reach the medial, the posterior part of the midbrain to go to the cortical region, and behind the tentorium. Here again, this branch. Here we have the calcarine artery and the division of the posterior cerebral artery. Here is the cortical part of the posterior cerebral artery. The vein of the drainage here is the vein of Garin with all the confluent from all the region of the cerebrum. The vascular anatomy of the tentorium. We are the supratentorial feeders and infratentorial feeders. The meningohypophyseal trunk, including the medial tentorial artery, Bernasconi, Cassianari, from the medial lateral tentorial artery, and from branches of the middle meningeal artery. In the infratentorial part, we have a branch of the ascendant pharyngeal artery, occipital artery, posterior meningeal artery, and the artery of Davidov and Schuster, branch of the PCA from it's originated from P1 or P2 and supply the 3 to 4 centimeter medial, the medial inferior surface of the tentorium. Had a nice paper from Korean neurosurgeon Shin Yu Lee, who studied innervation of the tentorium. As we know, the tentorium is innervated by the recurrent nerve of Arnold, and innerve essentially in this study. We see that more than 80% the tentorium the innervation of tentorium is located in the transverse sinus and the posterior half of the stride sinus. And this is and these morphological findings are consistent with neurological recommendation that traction or contacting the posterior parts of the falx of the cerebelli and tentorium cerebellar should be minimized to avoid hemodynamic problems. I don't talk about all surgical approach, but I want to treat the subtemporal approach only because there are many way and approaches to this region, and there is no best way, unfortunately. The subtemporal approach, John. Hi, John.
Yes.
Yes. I have some video.
Okay, let's try it. Let's try it.
Yeah. Excuse me.
Hello, Victor. Say hi to Saeed, Victor.
Do you see my slide?
Yes, I see the slide. Yeah, but no video. Just play the video like you would on your computer. That's all, and share the screen.
Okay. Okay.
Yeah, just play the video like you would on your computer and share the screen through the Zoom.
Okay. This is the video from I think Professor.
We can't see it now. You got to get off the screen share. Here, let me get you off the.
Yes.
Let me get you off the screen share. Hold on.
I start in a few minutes.
Yeah, you should be able to play the video now. Yeah, play the video now.
I start in a few minutes the video.
Okay.
Hello, Said.
Hello, Victor. How are you? Nice to meet you.
There's a
nice
Mr. Neuroanatomy.
It's a hard subject.
Well, you know, Saeed, Victor's helping us promote your talk right now. He's doing some excellent postings on the various WhatsApp groups.
Yes, I follow him.
Pictures of you presenting as well as a description. So
yes, I follow him.
Yeah, that's gold. That's gold promotion.
Yes. I continue with my presentation before the surgical procedure.
Okay.
The subtemporal approach was described by Drake in 1960.
Without seeing the video, Saeed, you're trying to share the video.
There's no video for the moment.
Oh, okay.
Just slide.
Okay. The slides aren't on either.
Yeah.
Sorry to be bad news, but there's no slides either.
Before to start a subtemporal approach, we need to know the anatomy of the drainage cerebral vein, and as we see here, we are the superior cerebral vein and excuse me, that's drain and the labby, and we have to respect this space, this vein, otherwise to choose another way to go. And here we have the basal vein more anteriorly, but we have a lot of posterior temporal vein and basal temporal vein that's drained into the transverse sinus. That's
Dr. Said.
Go ahead, Victor. Go ahead. Maybe if you tell him to share the screen, he'll listen.
You can say the slide?
No.
No, we cannot.
You don't say the slide?
No.
No.
Excuse me, what's happened? Peut-être I change.
There you go. Okay, make it big.
Okay.
Yeah.
There we
Okay.
go.
We should study the tentorial vein drainage before to go for subtemporal space, and we need to know where is the trochlear nerve, and this study from Tubbs, who described this linear meatal line that's located in the external auditory meatus. And just posterior to this line, 1 centimeter, we can reach the trochlear nerve and cut the incisura tentorial edge in the incisura. Excuse me. When we have tumor here and the anatomy is destroyed, we can go more posteriorly to reach the posterior parts of the cerebral peduncle to identify the trochlear nerve. Here again, we should know the superior petrosal venous complex before cutting the dura. Is it anterior, medial, or posterior? Before opening the dura and expose the infratentorial portion. Here, this is the presentation of Juha Haniasemi, that he allows me to present his videos. This is a park bench, lateral position, and sagittal suture parallel to the floor, and the head is tilted laterally to be more inferior on the base, cranial base. This is the incision, and here we have the temporal flap, and after we remove all the bone and the temporal bone and the mastoid to be parallel to the base, and after that we open the dura. The video. Do you see the video?
Not yet.
Not yet?
No, you're showing Juha's video?
Yeah, okay. I'm going to, okay. Excuse me. Why I haven't?
If you want to just leave
Yes.
the screen share and just play the video. and screen share that. You know what I mean? Come back and screen share the video. Do you
Yes.
know what? Is that complicated?
No, but put that here. Here. Yes.
Okay.
Oh, here.
Okay, there we go. Okay.
Okay. This is a right a female of 30 years old with a right basilar and superior cerebral artery aneurysm, a ruptured aneurysm. And there is a right here. And as we see, there's the level of the dorsum celli. Excuse me. Oh. This is you have. This is same surgery, fast aperture, clean, as he said. One borehole. We go from right, and here we don't make the borehole because sometimes we have mastoid here, mastoid cells. After hemostasis, we open the dura, triangulation, suspension of the dura. Before, this is the tentorium. We go slowly. And here we are at the system with the arachnoid. The arachnoid that stick here. We open the system. We aspirate. And open gently the arachnoid membrane. We identify the vessels. And here we retract the tentorium and identify the fourth nerve. Now we can cut the tentorium after coagulation. And suspension with a clip or two clips. There's a fast the suture. And now Professor Ernest Nieni open the mesencephalic leaf. found the aneurysm here. There is some perforated branch. We explore the base of the aneurysm. He put the temporary clip, basilar artery, below the perforating arteries, and put the clip. And he moved the clip. All basilar artery aneurysm of basilar artery is done by this way by Professor Ernest Nieni. And he has I don't know how many aneurysm by this way. So we stop yes.
We're having audio problem, a minor problem, it's not bad. Just continue on, that's all. It's just temporary.
Huh?
That's fine.
Okay. My presentation, where is my, here. Okay. I think I finish here.
Okay, very good.
Yeah,
That's a lot of territory you covered.
Yes, it's a long journey.
Yeah, it's like you said, it's very complicated.
Yes, very complicated.
Victor, I guess it's known, Victor, as a complicated part of the anatomy, Victor.
Yeah, of course. The complexity of this region is very important. So it's, of course, very complex, especially when you try to remove a tumor located in the tentorial incisure because of the cranial nerves that cross over that area, and also very small arteries and very important arteries. For example, the small branches from the posterior cerebral artery in the P2 or P3 segments. If you lesion one of those arteries, you could have a serious lesion in the brain stem. So, of course, we as brain surgeons should know the anatomy of this region before to try to remove a tumor located in this part of the brain. Really nice lecture, my friend Said Taha.
Thank you very much.
Really nice and really good pictures. Congrats.
Thank you very much.
Very good. Warlick, excuse me, go ahead, Said, I'm sorry.
Yeah.
Warlick, are you there? Are you there, Warlick? I don't know if she may have stepped away.
It was long for.
It's okay. Yeah, that's
It's
okay.
a long presentation.
Yeah,
but,
there's another Caesar Valley Rivera. I'm glad to see
Yeah.
Caesar here. He's a neuroanatomist from. Oh, there you are, Warlocks.
Hi.
Okay, Warlocks, you want to just correlate?
Yeah.
You want to just kind of coordinate things?
Can I please share my slide?
Sure.
Just a moment.
Sure.
We want to congratulate John,
It's an old picture
of the year 2020.
That's when I had teeth.
2020.
I had teeth.
Yes, for all what he does for our
Who made that?
neurosurgeon community.
Oh,
We thank you.
That's very nice.
We thank you. It's very.
That's very nice. It's very nice.
It's a great what you do. It's a great job. So for us, you are the man of 2020.
Should I cry?
Yes. Yeah, go. Victor.
Thank you very much. Yeah. This is a labor of love. This is really, and I'm so glad to have you guys on this platform. It's a fantastic platform.
Yes.
Meeting people like Victor.
You are generous.
From Japan.
You are generous. You are all time happy to when you are in all the webinars. And you connect all the person. It's a very good job. And for us, for neurosurgery community, you are the man of the year.
Okay, thank you very much. Thank you very much. Okay,
where is Warlocks?
Okay.
Go ahead, Warlocks.
Yes.
Yeah,
Warlocks.
we made it for you actually.
Okay, for those.
Yes.
Yeah.
So the next session is the questions, I guess.
Yes. Just for those who was not here, this is my hospital, and this is my team. This is Sebastian, Guillaume, Mohamed, our resident, Carl, with Thibaut, his car. I'm glad to work with them, and this is my friend from 3D Neuroanatomy, Pablo Gonzalez, Fernando, Victor Fernandez, Javier Abarca, Samer Al-Baba, Salman Sharif, Albert Sofianov, Thomas Tantarios. Thank you. And I hope we see you. And Stefan, we hope to see you in Alicante. This is my cat. And thank you. Yes, my cat.
Get Warlocks going.
Thank you very much.
Okay. I mean, definitely going to be like this cat about a cat, you know. Okay, next session is about questions, and if there's no questions, so we can skip to the Kahoot questions. Anyone have a questions, you can ask on the sites right now, or you can leave the questions on the chat box.
Yeah, okay. And the chat, because it's a long time.
Yeah, we can do the quiz after. Anybody any questions? Tasha, you have any questions? Or Dr. from Japan? For more, I guess he's okay. And Caesar, welcome, Caesar Valley Rivera, neuroanatomist from Peru. Hi, Caesar. Let me unmute you there. Okay, are you there, Caesar? Maybe, perhaps not. Okay. 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 Any Warlocks? You want to proceed to the Kahoot?
So next, I think if there are no questions, or maybe you can leave or the questions in the chat box, so we can skip to the Kahoot, right?
Yeah.
as John like
Are
mentioned
you
earlier.
excited? Are you excited about this, Rolex? I heard you didn't sleep last night. Is that true because of this Kahoot?
Yeah,
Yes.
so exciting because
Okay.
it's really complicated.
Okay.
Yeah.
Okay. This is
Just
going to
bring
be
it on.
competition, Rolex. You're going to be going against students. I mean, and I'm not going to, you don't have to identify who you are in Kahoot. Let me
Yes.
just explain it. I'm going to set it up right now. Let me just set it up uh, so that I'm playing it for everybody. No. Okay. No. Okay. Okay. I'm just setting up. Setting up. Don't worry. I got it. Okay. I'm going to share. Okay. We're loading up the pen. I'm going to share the screen. Everybody, I'm going to share the screen now to the actual Kahoot. Okay, now go on your smartphone. Here is the pin, 783-24-2489. That you go to kahoot.it, kahoot.it on your smartphone, and you put in that pin number like I'm going to do right now, and you're going to see me appear on the screen. Okay, I'm going to do it from my smartphone to show you guys. Okay. Okay, you got in there, Warlix? Just get in there. Warlix, are you in? Kahoot.it. And punch the pin in. There's only 2 people in there. Come on, guys. We've got to get at least 6 or 7. Okay, I'm coming in myself. And these are all questions made by Saeed about the topic. So it is, and we may have a round trip ticket to Reunion Island for 2 people. I'm getting in there, okay. You're in there, Warlix, okay? Warlix, are you in? You don't have to tell me who you are. Okay, Tashi, I hope you're in there. Okay, I'm in. Okay, 1, 2, 3, 4, 5, 6, 7. Okay. Okay, if everyone's in there, you don't have to say who you are because there are going to be winners here. And does anybody need any more time? I'll wait for more time. If I know there's a couple of players here. I know one of them, Prakesh. Let's see here. What's it? Let me see. Pragnesh Bhatt. I think he was a top player in prior. You don't have to say who you are, Pragnesh, but I'm sure you'll be at the top. Okay. 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 When we start, there's going to be a screen that you get to pick A, B, C, or D. You pick that on your smartphone. Okay, here we go. Are you ready, Warlix? Hello, Warlix. Are you ready?
Yes,
Okay, ready
yes.
or not? Here we go. Okay, here we go. Now be fast now. Here we go. Okay, very good. Okay, we got one right of the four. Okay, well, we got to get better. The correct answer is trochlear nerve, and one person got it. Okay, next question. Social lizard takes an early lead. Okay, next question. In the human embryo of 10 weeks, okay, the correct answer is D. Once again, one answer is correct. Then let's see who that is. Is social lizard got another one? No, red lizard came up there. Okay, next question. 3 of 10. The shape of the tentorium, which is tilted back in relation to? That's a, I kind of don't understand that one for me. Okay, we got two people got the right answer. The shape of the tentorium is the growth of the occipital lobe. It's tilted back by the growth of the occipital lobe. Okay.
The cephalization.
Oh, okay.
Mm.
Yeah, you can certainly comment if you want to comment. Wade.
Oh, that's good. It's good.
Okay.
We'll continue.
Okay, charming lizard has taken a lead. Which cistern is not at the level
Of the tentorium. Tentorium notch.
Okay, I have a feeling we're going to get that right. Okay, 6 got that right. Okay, excellent. Excellent. Okay. Social lizard creeps back into the lead. True to its name, it creeps like a lizard. Okay.
Probably I was not spared by the question.
Oh, okay.
Initially.
Give it the exact response. Okay, correct answer. Well, we fell back on that one. Only one person got it right. Okay, see who. Okay, Social Gator jumps into the lead for the first time. Okay. Give the wrong answer. Just 2 people answered that. That's kind of a tricky question. Okay, well, let's see. 2 people got that right. Curl between medial surface of uncus and cerebral peduncle. That was a tricky question, Saeed, right? Give the wrong answer, but I think that kind of threw some people.
Yes.
Okay, very good. Okay, on to the next one. Okay, 7th question. Okay, correct answer. One person got it right. The origin of the lateral choroid. Okay, next. We'll move along here. Social Gators crept back into the lead. It's neck and neck. Give the wrong answer. Okay, answer is B. Very good. 2 people got it right. That's great. That's getting better. Okay. Let's see what happens. Social. Oh my God. Charming Bison comes back from the pack. This is down to the wire. The last 2 questions. Okay. The right answer is, let's see, 2 people got it right. Great. Okay, great. Okay, let's see what happens
Last
here.
question.
Okay, this is the very last question. Glowing Condor. I think that's the first time they've been in the lead. Okay, last question. It comes down to the last question. This is maybe for a trip to Reunion Island, all expenses paid.
Yes.
2 people.
First
class.
First class.
Hey, maybe we could throw in a weekend in Paris in too.
Yes.
Okay. We finished with 1 correct answer. Let's see. This is the final toll. Let's have a drum roll, Warlicks. Okay, the 3rd place, Social Lizard. You get to drive when it's to the airport. Okay. This was Charming Bison. My God, Charming Bison. Now I don't know if I'll make you reveal your identity. Let's see. Okay, Charming Bison won, and I'm not going to ask anybody to reveal himself. Okay, let me stop the share. Okay, very good. Well, it's good we cover the topic. Maybe you could go a little deeper in some areas. But
yes, it's a complex region. It's not easy to.
Yeah.
Maybe it necessitates another presentation for surgical approach, perhaps.
Sure. Anytime you want. Now, I would like to go on a quick tour of Reunion. Would you guys like to go on a tour? Or you want to give us a tour?
On Reunion?
Yeah, could you? Why don't you go ahead and do that? I mean, it's a fascinating part of the world. I'd love to get to know it. And we can always edit this out for the presentation itself. Okay.
Yes. Okay. Let's slowly up.
So it's dark. Oh, white sand and dark sand.
The man.
There it is. Okay.
Okay. Here is where we are. Here, like at the point here. It's Madagascar. We are far from Paris by plane 11 hours.
Wow.
11 hours. And here we are near Mauritius. Seychelles are here and Madagascar here. Mm-hmm. This is the city where we are, where I'm, Saint-Pierre. And this is a beautiful island because there are many religions, many origin. They are Hindu, Chinese, Zarab, we call Zarab, the Muslim from Pakistan and from Gujarat in the Indian part.
So a significant part of the population is Muslim in Reunion?
We have Muslims, yes, the Pakistanis and the Indian from Gujarat are Muslims.
What percentage is that? About like 20%, 30%?
No. Less than.
Less than that. Okay.
Yes. Less. Perhaps 30%.
Okay.
I see. Yes. The originates of the population is from Madagascar.
Okay.
Yeah, and they are African origin, Indian origin, Chinese origin, and we live in peace. And here, the mountain, the sea, here the volcano, it's magnifique.
So when's the last time? It's active volcano, right? When's the last time it exploded?
This time now, but when it starts to all the population go there and camping, they say the spectacle is very it's spectacular.
Yeah, it looks marvelous.
Yes, but it's a class B. Class B is not aggressive. And this is my team and my colleagues.
Do you guys cover the other islands? There's another couple of islands, or do they all fly to your island?
Yes. We go to the next island, French department at Mayotte.
Okay.
It's the last department in French, and all they have not neurosurgical units. They come from Mayotte to our island for operation. And for operation, we do all intervention from pediatric to the old patient, tumoral, traumatic, vascular, endoscopic. We have C-arm. We have modern operating rooms and modern for radiology. We have all modern tools for working.
Okay. Does anybody have any questions of the neurosurgical setup on the island, or comments? Yeah, we had a presentation by a neurosurgeon from Sri Lanka the other day, Saeed. And,
yes.
You know, there are limitations on what you can do with testing, of course. And I guess everyone comes to the main island to be tested. There's no MRIs or CT scans on the other islands, right? They all have to come to the Reunion.
Yes, the Reunion Island, all Reunion Island, we have one department, and from Madagascar, they comes from Madagascar, from Mauritius, from Seychelles.
Well, the neurosurgical cases from Madagascar come to you?
Yes. The problem is the money.
Oh, in Madagascar, there's not many centers, neurosurgical centers?
They had, but they had not
machine, CAT scan.
Machine, yes.
Okay. Well, I didn't know that.
They have good neurosurgeon, but they need more technical
support, right?
Support, yes.
Yeah. Okay. Okay. Very good.
And we will work together to develop our all the island around the island. It's the project, but the problem, there is a political situation in each island is different.
Is Madagascar French territory also, or no?
It's all the independent. Yes, are independent actually.
Okay, very good.
Say, Taha.
Yes.
My friend Taha, I want to ask you something.
Yes.
Is how is COVID disease in Reunion
We
Island?
have very few cases in our island. Not much.
Very few.
We are protected. We are protected by from the.
There must be restrictions, travel restrictions, right?
Yeah.
You have to be tested when you come in and stuff. They have that kind of restriction, travel.
No restriction from France.
They're starting to vaccinate. They vaccinate here in Miami. I don't know.
Yes, we start.
You start too? Okay.
You start too.
The whole world seems to be starting.
Yes. Yeah.
Actually,
we start vaccination.
Does anybody else want to weigh in with a comment or something to say to Saeed about the neurosurgery setup or whatever? Or just introduce yourself. Roman, how you doing? Roman Jack, I know you're from Slovenia. We have a webcast with Vinko on the 15th, Roman. I'm sure you know Vinko. Okay, very good. I'd like to thank you very much, Saeed, for everything.
Thank you very much. Thank you, Victor.
Thank you.
Hi,
you
Victor.
so much.
Next,
thank you.
Thank you very much.
We're just going to sign off here. I'm going to stick around. Now, stick around, everybody. You can always network, okay? So I'm just going to stop the